Welcome back to this week's episode of the Caregivers podcast. I'm your host, Dr. Mark Ropoleski, and you can call me Dr. Mark. Today, we're talking about endometriosis. It affects roughly 1 in 10 women and girls of reproductive age, yet is still too often reduced to bad cramps, a heavy period, or something women are just expected to push through. But for many women, endometriosis is not a minor inconvenience. It is a pain that can reshape ordinary life. It can interfere with work, intimacy, parenting, caregiving, sleep, energy levels, mental health, and the ability to move through a normal day without having to hide what's happening inside your body. And for many women, one of the hardest parts is not just the pain itself, it's how often they're left carrying it alone, trying to function, trying to earn a living, trying to look okay, trying to explain something that many people still do not fully understand or believe. Our guest today is Dr. Laura Katz, a clinical health and rehabilitation psychologist and assistant professor at McMaster University, and the co-founder of Endometriosis 360. Today, we're going to talk about what endometriosis actually is, what it feels like to live with, and how it reshapes intimacy, work, and everyday life, and what women can actually do when proper care is hard to access. Dr. Katz, welcome back to the Caregivers podcast. And before we begin, please take the time to subscribe to the Caregivers podcast on Apple Podcasts, Spotify, or wherever you listen. Leave us a comment, leave us a review. It would really help. It's free and it takes just a second, and it's the best way to support the show. Laura, welcome back to the Caregivers podcast. So happy that you're here to join us once again.
It's great to be here. Thanks for having me back.
Well, in the tradition of the podcast, we're going to jump right in. Today, we're talking about endometriosis and acknowledging that endometriosis affects roughly 1 in 10 women and girls of reproductive age. Yet a lot of people still hear it dismissed as just bad cramps. So tell us, what is endometriosis actually?
Endometriosis is such a complex, not only a gynecological condition, but a huge systemic condition. And so, of course, we know the actual pathology and physiology of what the condition is, but what we're starting to understand is it's just so much more. So because it affects somebody in such a young age and there's such a long length of time that they have to go through with maybe having their symptoms not properly validated, heard, assessed. And so it might be up to 10 years by the time they actually get the kind of assessment, diagnosis, and treatment that they require. And so by that time, it's taken such a huge impact on their physical life, their relationships, their occupation, their family, the different roles they play in society as a whole, the workplace. And so when we just dismiss endometriosis as bad cramps, we fail to acknowledge the huge systemic load that it really takes on women, within our society.
So for the woman listening at home to this, how might she know if what she's experiencing could be endometriosis, and what are sort of the symptoms and patterns she should be paying attention to?
That's a really great question. And, we know from a lot of women, particularly, before they're able to get to healthcare, maybe get that kind of assessment and diagnosis, it may show up with having utterly debilitating cramps, and not to the point where it's uncomfortable, but they have to take time off school or work where, they're bedridden, they're curled and hunched over. It's going to affect your GI system, potentially really heavy bleeding. As you start to get upwards in life, it might start to affect things like fertility. And so if this is somebody listening and you have been somebody that have really struggled with incredibly painful cramps, periods, and bleeding, and it hasn't been assessed, this is something that you might want to start listening to and seeing if some of those things are affecting you.
So Laura, for women living with endometriosis, what does it actually feel like day to day, especially when it's at its worst and starting to sort of take over your life?
The really tricky thing about endometriosis is the unpredictability of the symptoms. And so you kind of live within the cyclical nature of the menstrual cycle. And for a lot of women, they may only get 7 to 10 good days per month. And then as soon as they start to hit that luteal, premenstrual, and even menstrual phase, you really start to experience quite significant symptoms. And so, because of that, the unpredictability about, can I eat this food? Am I going to be able to go to work today? Am I going to have a flare up that's so bad that I'm not going to be able to function? And so those are some of the big things that really strike, is the total unpredictability and the uncertainty of how it's going to impact women day to day in their life.
Now, you've got broad experience in your practice and in discussions with colleagues. Are there women who actually don't get that 7 to 10 day break and suffer
Yeah.
chronically through the month?
Absolutely. There's a lot of women who may not get any days break, and it might just feel completely different throughout the month. And there are a lot of treatments that, hormonal treatments that women may be on, that may dial down the symptoms so they're not as painful throughout different times of the month, or they may, skip periods so they don't have the symptoms as bad or the heavy bleeding and pain. But it really varies. And for a lot of women, they may not have any good days whatsoever at all.
We all have different pain thresholds as individuals, but when women describe endometriosis pain, what kind of pain are they actually talking about? Help us understand the level and severity of it.
It's a really good question. And I work with a phenomenal pelvic floor physiotherapist, Jill Mueller, and she loves to describe the story where she herself is somebody with lived experience and has endometriosis. And because she's suffered all the pain and cramps and all of that for many, many years, she chose to have childbirth with no anesthetic and completely medication free. And she said that the endometriosis cramps were at times worse than childbirth. And so that's some really strong experience and a really good example of how the pain can be utterly debilitating to the point where it can be compared sometimes to childbirth and contractions.
It seems to come up again and again, this one phrase in this community of individuals when they speak of their experience or they reflect, nobody believed me. Why is
Mhm.
being believed such a central part of the endometriosis experience?
It's such a central part because the majority of these women have had their symptoms dismissed for upwards of a decade. And so it's been 10 years plus of debilitating pain where they've been given treatment recommendations like have a bath, try to relax, do some yoga, and you're trying to tell somebody with the pain experience equivalent to childbirth to go take a bath and relax. And so 10 years of that, and then they finally get this diagnosis. By that point, it's been a decade of their life that has been totally identified with struggling to cope with such a condition.
And that those years probably build on each other.
Mm-hmm. So it's years of school and friendships and university or college and careers and jobs and, meeting partners and trying to have children, some of the most, formative years in somebody's life. And this is often what somebody can really identify with and become such a strong part of what they have to live with day to day.
So women who listen to this show have shared that doctors told them that they were just experiencing a heavy period and
Mhm.
put them on birth control. And I mean, what does that kind of minimization do psychologically, especially when it happens again and again? And you allude to the length of time, which I think is supported by the research literature, that 7 to 10 years is not off the table in terms of the amount of time you live without a diagnosis.
What it does is it starts to centralize and sensitize the nervous system. And when I work with patients, I talk a lot about the neurobiology of pain
Mm-hmm.
and how that leads to different kinds of sensations in the body. And so when patients are continually going in to seek treatments and their symptoms are getting invalidated and dismissed, what that ends to leading to is the fact that they feel more and more unsafe in their bodies. And they don't trust their symptoms more and more and more. And over time, that starts to sensitize and centralize all of the fight or flight symptoms that are happening in their body, which essentially leads to medical trauma. And so a lot of the women that I do work with, when they've had these decades long period of invalidation and medical procedures and being dismissed and discharged and all of that, what it leads to is the fact that they don't know what's happening in their body anymore and they can't trust their body. And there's this real hypervigilance of their symptoms and experiences, which makes a total amount of sense.
I mean, from what you describe, it almost seems like the sensitization overwhelms the executive ability to just plan your day, plan for what you need to accomplish, no matter what role you occupy in your life and the life of others.
It does. It absolutely does. And when we start to think about, what the science is behind that, this is a safety mechanism that has helped us survive for many, many, many years. And while it made a lot of sense for us to have this system in place while we're running from bears or, we're living in caves and things, it doesn't make a whole lot of sense in our modern day lives when we're going to doctor's appointments or checking emails. And so because of that and all of the hypervigilance that's experienced, it just hijacks that system. And you're right in the sense that it overloads the ability to function in our modern day life.
So, I mean, what does it do to a woman over time to have endometriosis dismissed and minimized and maybe misdiagnosed or treated as though pain is just a normal part of being a woman?
I think it becomes really central to an individual's identity in the sense that they start to learn that their bodies aren't safe, the healthcare system and medical practitioners aren't safe, and they start to feel really out of control in their selves and their environments, which decreases their self-efficacy, which means they don't know what to cope. So in some cases, they just give up. Because if they feel that they don't know what to do to cope and nothing they've ever done has worked, then what's the point of anything? And that can lead to some really scary places.
So then, once you've actually been taken seriously and receive a diagnosis of endometriosis, what is the typical treatment plan that a patient can expect to be initiated, at least the first steps?
So the first steps is so typically speaking, historically, surgery has been needed for a definitive diagnosis, but nowadays, ultrasound guided diagnosis is becoming more and more popular. It's minimally invasive, of course. There's not a whole lot of risks involved. And so, with that, if you do happen to get a diagnosis, and a lot of the times, if people don't even have access to those kinds of resources, a lot of general practitioners are starting to assume a diagnosis given the symptoms and the experiences that people are having. And so, even with an assumed diagnosis, treatment might look like anything from starting some kind of hormonal therapy to kind of dial down the hormones and, all of the bleeding and the pain. It might involve some pain management medications. It might eventually involve some surgical treatments and things like that. But ultimately, what we know to be some of the best quality treatment for endometriosis is assembling some kind of multidisciplinary or interdisciplinary team. And like I spoke about at the beginning, this isn't a gynecological condition. It's not just pathology in your uterus. It really encompasses so much of your systemic overall being in terms of your psychology, the kinds of foods you eat and how it impacts your digestion and your body, your movement and your physical ability to, navigate your musculature, and so much more. And so treatment can look like a variety of different things given people's resources and, how they're able to assemble different practitioners working with them.
I mean, you bring up a good point in that it's not just a condition of the uterus or immediate surroundings, but these tissues can migrate inside the abdominal cavity and implant in different spots, giving symptoms in areas which we typically would not ascribe to endometriosis as being the top 3 causes for pain in that area, knowing that other things are much more common. But at the same time, they can be real. I mean, I've had patients in my practice who have gastrointestinal bleeding every month because of implants of endometriosis that have kind of burrowed through and just cause enough swelling and reaction to cause bleeding cyclically like that. Obviously, we're called to ask to make sure it's not bleeding from something else, and we often support our gynecologic teams in that way to help clarify and sort of help them steer the direction the right way. So you mentioned something really important, that there's a multidisciplinary team. What is the ideal approach, and what is the ideal scenario that endometriosis would therefore be treated?
I think this varies so much based on what kinds of resources are available. And so it might look different for somebody in different areas in terms of, what kind of resources they have access to and so on. If they're urban, if they're more rural, and all of those kinds of factors.
Yep.
Big issues for sure in terms of the access of healthcare. Ideally, you definitely want medicine involved. And so sometimes I've seen, individuals they'll have endometriosis lesions all the way up to their diaphragm, all over their GI, like everywhere you can think of. And it might even be the case that, a gastroenterologist might be able to see them sooner than a gynecologist. And so again, it's the bouncing back of the medicine, but obviously having a medical team is a really important part of this condition. Another really important part of a multidisciplinary or interdisciplinary team for endometriosis is some kind of pelvic floor physiotherapy. We know that because of the location, there's often a lot of hypertension in the pelvic floor, which means the muscles are really, really tight. And that can cause an incredible amount of pain just for day-to-day life and movement and activities, sexual functioning, going to get, medical exams and so on. And, being able to find a pelvic floor physiotherapist who has training and understanding of both pain as well as conditions like endometriosis. So not all pelvic physios are made alike. Some have excellent training in, antenatal, postpartum pelvic floors, but you're going to want to find somebody who really understands pain conditions and how to deal with the pelvic floor in that way. Because if you have somebody, for example, that doesn't know the condition and just starts to do internal medical exams, it's obviously going to increase the pain and all of the hypertension and sensitivity, and that's not going to do a whole lot of good. And of course, you want to have somebody mental health wise. It's the chicken or the egg. Are people experiencing mental health distress before a condition like endometriosis? Or are they experiencing mental health distress because of all the systemic issues that something like endometriosis is bringing about? And it's usually some combination of the both, of course. And so having somebody that's a mental health therapist or practitioner involved in your team can be really helpful, particularly if they know pain science, if they understand women's health issues, and if they can help you cope with things like low mood, depression, anxiety, and potentially trauma as well. And a third person that you really want to have on your team is somebody like a registered dietitian or a naturopath, somebody who really understands, what's going on in terms of the gastrointestinal symptoms and food and eating. And it may not be your typical person to just tell you, this food is good, this food is bad, because what we know is there's so much disordered eating in this community because you're trying to find foods that feel safe. And in doing that, everything just becomes so reactive. And so with that, I'd love to give, a shout out to my team. Of course, we have Dr. Matthew Leonardi, who is our gynecologist on our team for Endometriosis 360. Myself, I'm a health psychologist and I lead up all the mental health on the team. We have Emily Arthur, who's a registered dietitian who does some incredible work on not just telling you what food to eat, but specializing in endocrinology and food trauma. And then our incredible pelvic floor physiotherapist, Jill Mueller, who does some fantastic work in somatic therapy on trauma in the body and pelvic floor. And so this, of course, we've created the ideal, but it's a little bit different flavor than just going out to your local physiotherapy office and trying to have somebody help you with strengthening and doing Kegels.
Part of our discussion today was to give our listeners that sense that they still can be empowered to build on things. So let's bring it back to grassroots. Someone is suspected diagnosis, they have a long waiting list to access consultation in gynecology. Their family doctor starts them on some medication to regulate their menstrual periods. What is the next logical thing to add on to that so our listeners feel like while they're waiting and they may not have access to a team like yours, what are the next logical steps they can add on to that?
There's so much that people can do. And just in knowing that endometriosis is more than just a medical condition, hopefully can give some people out there hope. Because there's a lot that you can optimize in terms of your body and your environment so that when you do start to get in to see a gynecologist or a specialist, you're in a very different place and the treatments actually might be more effective. And there's tons of research to support that. And so Grassroots, doing some reading in terms of pain science and the nervous system, there's some really great books that are accessible, aren't too expensive, and go through a great amount of detail. I love The Way Out. I can suggest some other ones as well.
Yeah, we'll definitely put those in the show notes for sure.
Mm-hmm. So some great books to learn about, pain science, about how things like mental health really impact our bodies and our nervous systems and, how pain signaling works. And there's a ton of free resources online that you can access these kinds of things in different areas from a cognitive behavioral perspective. Mm-hmm. There's tons of resources online too about starting to move your body and do these kinds of exercises that can really help to start to release the pelvic floor. And so you don't necessarily have to have this dream team and, go through a lot of the programming and things. You absolutely can start to put all the pieces together because each piece may be only 5-10%, but all together that would equal up to 50. And if you can optimize your body and your nervous system by adding all those puzzle pieces together, by the time or if you do get to medical treatment, it's really going to have such, an impact and treatment's going to be way more effective.
And that's a common theme that resonates with chronic pain. In my experience in managing patients with irritable bowel, the same issue is that several contributions, each contributing 10 or 15%, can really add up. But you need to be of the mindset to invest in each individually, not in expecting any of those to hit the ball out of the park, but together to result in some benefit. So I'd like to change gears a little bit and start exploring some of the bigger impacts of endometriosis on the lives of women affected. In your experience, at what point does endometriosis really start deeply affecting a woman's relationships, intimacy, and her sense of self?
I think it always does. And so endometriosis is often a condition that's experienced at the beginning of menstruation. We have a lot of youth and teens and young adults. And so you start to have that relationship with your body from a very early age, which can be incredibly difficult for intimacy and forming relationships and so on, and finding partners that might be supportive with these kind of issues. So I don't think it's a matter of when does it start. I think it always kind of is.
They speak of a relational tax that comes with the diagnosis of endometriosis. What do listeners gain from an understanding of that?
There's a relational tax in the sense that there's somewhat, I don't even want to call it a responsibility, but being in a relationship with somebody with endometriosis, it requires some level of empathy, understanding, and supportiveness to know that symptoms may be unpredictable. There are times that functioning and roles will change. And so, you see the whole range of the kinds of partners that women may have when they have endometriosis, everything from incredibly supportive, good communication, being able to talk about what needs might be that varies, by day, by time, versus, the partner who really doesn't get it and maybe very solicitous in their support and passive aggressive, and, shutting down and people moving away from each other in their relationship. And it even gets to the point where we talk a lot about intimacy and the kind of work that I do in our programming. And we talk about things, such as the factors of why do people have sex and why are people intimate? And there's approach reasons, of course, because we want to feel closer, we want to feel good. But there's also avoidance reasons because we don't want to have that fight. We don't want to have to go through that conversation again. We don't want to have to say, I'm in pain and deal with the negative consequences. So when you're talking about a relational tax, that's part of, the atmosphere and the environment that you're coping with in terms of there's a lot of different factors that bring people together that are approach related, but there's also a lot of avoidance related factors that can bring people apart.
There's also a lot of learning that can take place to actually reestablish, if you will, a new code of intimacy that's unique to that partnership, which may need to be modified or adjusted in an adaptive process, but one that still can holistically keep people intimate and close and in touch with each other.
Yeah. And when we talk about intimacy and sex, particularly with, endometriosis, we don't want to do things that hurt. So over time, if sex and penetration and intimacy hurts, our bodies shut down. And there's that whole cycle where we're avoidance, we're emotionally distressed, we shut off, it changes our pelvic floor physiology, our arousal and desire. And it makes a lot of sense that we don't want to engage in intimacy for future occasions. And so, we really start to understand that there's so many factors that impact arousal and desire and intimacy. And so where we once maybe thought of intimacy in terms of that linear model, we now understand it to be much more circular and fluid with a variety of factors that impact arousal and desire at all different stages. And sometimes we start at one place and we end off, and that's okay. And I work with a lot of couples in terms of understanding their own individual factors to be able to feel safe in their bodies and feel safe in intimacy once again with their partners and with themselves.
I mean, that's huge that you mentioned working with couples, because even the presence of your partner at a medical appointment has actually been shown to maybe improve listening skills. I'm not sure what it is, but actually your chances of being referred for next level consultation where a diagnosis of endometriosis is actually made has been shown to be associated with the presence of your partner in the room, which I think is fascinating.
That is.
For many women, though, with endometriosis, as physical intimacy can just become so painful. I mean, what starts happening to closeness and connection when intimacy becomes associated with only pain or fear of pain?
It starts to degrade. So where it might just start with intimacy, it's obviously going to continue on to different levels of the relationship. Because if you feel vulnerable and violated and dismissed in your body during intimate moments, then it's hard to just snap out of it and go back to your regular everyday relationship. Because, you are a whole part of your body. It's part of your identity. And so it definitely carries through to all different realms.
People speak of the loneliness associated with endometriosis, but there's also reference to double loneliness because without that communication element, the partner can also feel very much alone. How do you counsel couples? What's your strategy to get them on the same page?
It's really tricky. And so I think that there's so much that can be done in terms of education. And so I don't, fully do couples counseling, but of course I will
For sure.
counsel couples who, come forward with these kind of issues because I think there's so much that can be done in trying to help the partner understand what is endometriosis, what happens in their body, what's happening in terms of their physiology and all of the science, because the partner can't live inside, that woman's body and understand the kind of symptoms that are happening. And sometimes just understanding what that science is can be so helpful in terms of it's not just this, it affects so many different things. And so just having that education there is a first part. And then, starting to understand and help the couples understand their dynamics in terms of what brings them together and when they start to retreat. And so maybe understanding, one person ends up retreating with these kind of dynamics and these kind of factors, but essentially you want to start to get them moving together because more often than not, they both have the same goals. They both want to feel closer. They both want to improve the relationship. They both want to have communication. They both don't want to be hurt. But you can get so easily stuck over time in those dynamics and that vicious cycle. And so helping couples cut that cycle to be able to come closer together with a better understanding can be so helpful.
I mean, having your partner just not get it is a huge obstacle. And in my practice, patients with Crohn's disease, I recall a time of women in tears saying that they don't get it. And it's a huge call out for the educational component of learning to live together when one partner has a chronic condition that has the potential to reshape everyday life.
Absolutely.
So for women living with endometriosis, talk to me a little bit. What does fertility uncertainty do to the way they think about their body, their future, and the possibility of pregnancy?
It's such a huge factor. And so a lot of the younger women that I've worked with, even before even having a partner or wanting to have children, there's this underlying fear and anticipation that they may not be able to, or it might be incredibly difficult and stressful. And so knowing that even before entering to a relationship, and then also at the beginning stages of the relationship, knowing that that is a factor and, starting to tackle all those logistics together. So we know that if this is something, starting to understand your fertility and going to clinics is something that you definitely want to do sooner rather than later. And then for a lot of the women I work with as well, maybe they've struggled with infertility for 10, 20 plus years. Maybe they were able to have a child, maybe they weren't, but it's processing that loss and that complex grief that they've experienced and not being able to understand what's happening in their body and maybe being dismissed from a fertility perspective when endo might have been there all along and not investigated or treated.
That is a huge grief and burden to carry if there's no room to talk about it, to express it. So communication is just so important. and in so many chronic conditions. That's such a huge step. Day to day, women live with the reality of endometriosis. And for women with that condition, it's not a shared burden. It's something that they're carrying largely alone, oftentimes. How does that isolation actually shape the experience of the illness?
It's a big one in the sense that by the time a lot of women will have reached out to somebody like me, being a psychologist, they've carried that burden on their own for so many years. And it's tricky because sometimes they might reach out or find individuals on support groups and corners of the internet. And while this might be helpful for forming some kind of a community, most people don't go online because they're having a great day and they want to share their experiences. Most people on the internet are there because they need to vent and they're having a really hard time struggling. And so a lot of time within communities of endometriosis, not only are you feeling alone, but when you do try to form a community and join others potentially online, it's not a really safe space and it's quite negative. And so it's that bouncing between, how do I connect with others in a really positive way so they feel like other people understand me and my symptoms and what's going on in my life versus getting dragged down by some of the toxicity in the online support groups.
So I can appreciate that there are places where we need to vent. The hope would be that there's some positive experiential communities where people are onboarded for the reason of growing together. And in this day and age, we might need to rely on those resources, as so many point out, in different forms of caregiving, for example. How and can we find those more constructive communities, or ones that help individuals build while they're waiting for consults, while they're waiting for next level care once they have a diagnosis?
You can definitely start by reaching out to some of the bigger organizations. So, in Canada, we have the Endometriosis Network of Canada. And, there's larger overall support networks and groups associated. You might have local chapters and groups that, connect and have all sorts of events. I think it's tricky in the sense that, as part of Endometriosis 360, we've also created a community as well. But even within that, it's so tricky because people just desperately need that space to vent. So even in the best of communities, there's always going to be some moments and pieces of negativity. And so it's almost as if, I don't know if there's one space that's totally safe and devoid of all these kinds of experiences. You just have to know when to tune out and notice when it's time to check out and leave.
Yeah, I think expecting one space to be the ultimate space probably would be very realistic either. It kind of takes the humanity out of it all. What do women with endometriosis really get good at hiding or downplaying just to get through their days?
There's a huge amount of masking. So
tell me more.
Yeah. So masking in the sense that pretending you're just okay. So putting on that smile, functioning at work, breathing through the pain, just ignoring what's happening in your body, often to the point where you go, push, and then you just kind of crash and burn. And that cycle, you go, push, and then crash and burn. So it's that cycle of masking and overdoing that a lot of women with endometriosis struggle with, because relationships and families and workplaces and our overall society and environment, there is no space to take a day. There are no resources. We don't live in villages anymore. And so there often isn't that opportunity to take that break, do the self-care, rest, do the things that you need to do to regulate, to come back to the place that you can function at some level of your normal self. And so because that doesn't exist in our society, there's just so much masking for women to continue to function in all the roles that you need to carry, and it's heavy.
Endometriosis really doesn't wait for your day off to come around. How does it get in the way of work, parenting, and ordinary life?
I would say it's not that it doesn't wait for a day off. It actually waits even more for a day off, in the sense that what can be such a struggle is you spend all of your energy and efforts and self-regulation doing the things that you have to do, like work and making money and, doing all the things that are absolutely a necessity to survive and live in this world. And then it creates a tax and a toll that maybe you get home at the end of the day with your partner and your kids, and you got nothing left. And you're lashing out, you can't function, you can barely hold yourself together. And maybe that's what a weekend looks like. So maybe you held it together all week, and by weekend, you just have nothing, and you don't even get to be able to enjoy your family or leisure or doing things, together, because you've just masked and held it all together throughout the week or during the day.
Throw on top of that sandwich generation caregivers who have aging parents they need to look after as well. And it almost seems like a perfect storm.
It is the storm. Yeah.
I'd like to take a break, and we have something for you we'd love to hear your thoughts about. We'd like to play a clip that recently was out on social media that's particularly valuable to this discussion, and look forward to hearing what you think.
Period pain can be as bad as the pain women experience during the second stage of labor or even a heart attack, and yet we are told to suck it up. Across the U.S., millions of women have to choose between working through unbearable pain, losing income they can't afford to go without, or tapping into a very limited number of sick days that they won't have if they have the flu or a doctor's appointment. I've introduced legislation to give workers up to 12 days of paid leave a year for reproductive health. This would cover period pain, yes, but also menopause symptoms, IVF, miscarriages, endometriosis, flare-ups, and more.
So, Laura, we'd love to get your feedback on that clip and your thoughts about how innovative it is.
My thoughts are that I can't believe we're just doing this in 2026. In a way, this doesn't feel innovative at all. It just feels human and like basic human ethics and rights. If you are in so much pain because of what your biology is doing to you, to the equivalent of second stage labor, and society is expecting you to work without consequences, something feels very wrong. And it feels equivalent to the fact that women continue to experience symptoms for decades within the medical system without being heard. And so, yes, this is a really innovative concept, but it feels like it should have been passed decades ago.
Well put. I couldn't agree more. When women talk about an endometriosis flare-up, what's actually happening in the body, and what can they do to get through it?
It really varies what's physiologically happening in the body. And sometimes it really is just biological, but there's so much you can actually do to work with a flare-up, to help mitigate it, to decrease, all of the dysfunction and the pain and the suffering that comes from it. And so it can be really helpful. One of the biggest strategies that I talk with patients when I work with them is just the simple act of noticing. So noticing what brings on flare-ups for you, and we don't want you to have that like hypervigilant with logging and tracking every single thing, but noticing maybe the day before, or are there particular events or people or activities or foods or anything that might lead to an increase of a flare-up. And sometimes there are, and sometimes there are not. There is the unpredictability of the condition, because if you can notice those things, you can mitigate and work with them. Sometimes we can't, and flare-ups are just going to happen. And that's really when you start to build your toolbox. So when you do have a flare up, what's going to help for you? For some people, it's lying down. For some people, it might be heat. It might be taking certain medications. It might be certain kinds of movements. It might be distraction. It might be different kinds of practices that you do. And so noticing and trying different things out and seeing what helps and having that toolbox for when these kind of flare-ups do happen, you can work with it. And part of the importance of working with flare-ups is the psychology of it. Because when you understand the neurobiology and all of the pain systems, when we feel pain and then we get in our heads about how scary and catastrophic and how dangerous and how bad it was last time, and it's going to topple me over and I'm not going to be able to function. And we start to build up that anticipation in the pain, that of course is not going to help. And so working with your own psychology and emotions and thoughts, because the thoughts have so much power over the body and how it reacts to the sensations that people are experiencing.
Clearly not a one size fits all, but really a size that's shaped by one's own engagement and trying to figure things out and turning to those resources where they can. And when you mentioned medications a couple of times, I think it's an important plug to put in here. Narcotics are really not an answer in this case, are they?
No, and we know from enough research that quite often with visceral pain conditions, narcotics don't necessarily do anything in terms of decreasing your pain levels and intensity. What they do is they make you dissociate, check out, and feel really drowsy, which sometimes can help because you're not conscious to experience the pain, but it doesn't help the pain. And so if rest and, disconnecting from what's happening in your body is what you need, there's definitely other practices that you can use that aren't medications, habit forming, and like narcotics.
And certain experts advocate for brief treatments with typical anti-inflammatories. Do a lot of patients in your practice take advantage of using those for a couple of days just to take the edge off pain-wise, and assuming that they're safe to use in that particular individual, because certain people can't?
Like NSAIDs?
Yes.
Yeah, absolutely. And the unique qualities of endometriosis is they often follow the cycle, right? And the different levels of hormones. So it could be nice in the sense that it might be very predictable, where you might only use NSAIDs or some kinds of medications for 3-4 days of your cycle. You know when they are, you know how to take them. And so it doesn't feel like you're constantly taking medication and getting the negative side effects. And so because of that cyclical nature, a lot of patients do and have some really good effects with it too.
So, I've heard over the years of individuals using anti-inflammatories to help regulate menstrual cramps. Does that mean they have endometriosis and they don't know it?
Not necessarily. I think you're probably a better expert than me in the actual physiology of how anti-inflammatories work in the body.
For sure.
Of course, anti-inflammatory medications, they decrease the amount of pain that somebody experiences, but it is normal to some extent to experience some level of discomfort associated with cramps. And so does that mean that it's endometriosis? Not necessarily. It really is such a subjective experience in terms of what that pain is to the person and how much is too much. And so if this is a question, that's a great example of to go speak to a medical professional, potentially get some testing done. But and just because an NSAID works doesn't mean that you have endometriosis. It could just mean that you're experiencing pain and it's helping to do what it does in the body.
So for women listening who don't have access to a full care team, let's give them a bit of a game plan. Where do they start? And what's the best evidence?
The evidence is at looking at the body holistically. So you might want to start by checking out some of the organizations in terms of endometriosis and some of the recommendations and resource pages that they have on their website. Like we spoke about, maybe it's looking into some mental health material. Maybe it's looking into some body and somatic practice material. Maybe it's looking at, some food and dietetics and, how your eating patterns might be influencing things. So I think if you were to start, with a plan for yourself, it might even be just noticing. So taking a couple days or a week or so to jot down symptoms and practices and thoughts and emotions and movements and what's happening, so you can get a better sense of what are some areas in particular that might be the most helpful for you. And then looking to some of the bigger endometriosis related organizations to start getting some access to resources and different things that they might have.
So if a woman is living with endometriosis and they're having to plan for the next flare before it hits, what absolutely needs to be in place, or how many recurrent cycles does it take to get a sense of what they feel, what they see, what it's like being present with the condition?
It varies, right? For one woman, it might be the aha moment of understanding their nervous system and their pain responses and really getting the biology. And as soon as they get that, next cycle, they know how to work with it more intuitively. And for some women, it's going to be a lot of trial and error. And, there's 2 steps forward, 1 step back. Progress isn't always linear, of course. And so I think it really does vary. And there has to be some level of grace and self-compassion that you have for your body, because
that's huge. Mm-hmm.
It's huge, and we can't fight biology. You know what I mean? There's a lot that we can do to optimize, but, we still have tissue and hormones and, all these biological factors that are real and make endometriosis, a significant systemic condition. And so while we can work with lots of these different kinds of therapies, we also have to acknowledge that there is the medicine and the medical piece as well.
That medicine and medical piece can have, such a strong impact. And as you said, that sort of compassion towards that reality. But I think you need to also be compassionate towards yourself and the efforts that you're making. And as you said, one size doesn't fit all. And there may be a step forward, a couple back, 2 steps forward, 1 back, maybe then no progress one time, then a step forward, then a step back. Be compassionate to yourselves. And it's probably, as you're trying to navigate different hurdles, not just the endometriosis story, but I think this applies to a lot of things. But show yourself that self-compassion, because at least you're showing up and you're trying.
Mm-hmm. And it goes a far way.
It does. What gives you the most hope for women living with endometriosis today?
I'm so hopeful because over the past few years, there really has been this influx and vortex of positive change and movement in terms of the science, the research, what's happening in our society, the medical systems, how we're treating and noticing endometriosis. There's a buzz. And so it gives me so much hope that things are finally being heard and listened to. And women are going to finally get all the research and the practices and the healthcare that they have deserved for so many years and decades.
What a perfect point in our conversation today, with hope and a vision for the future. Laura, I wanted to thank you for joining us. It's been wonderful to share this discussion with you, and to give our listeners a chance who are spending days suffering, days trying to get through, and hopefully bringing them a next level of awareness that'll make change possible.
It's great to be here. Thanks for having me on such an important topic.
That wraps up this week's episode of the Caregivers podcast. I'm your host, Dr. Mark Ropaleski. We'll see you next week. Dr. Katz, thank you for helping us speak to the day-to-day reality of endometriosis with honesty and care. I think one of the clearest reminders from this conversation is that endometriosis is not just pain. It's something women are often forced to carry largely alone while still expected to work, function, and keep life moving as though nothing is wrong. For the women listening who are living with this, I hope this conversation helped you feel seen, believed, and a little less alone. And if this episode meant something to you, please take a moment, rate the Caregivers podcast on Apple Podcasts, Spotify, YouTube, or wherever you listen. It really helps other people find the show. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.